Charlie Brown said it always rains on the unloved. Here in Oregon, we are going to be definitely unloved this week. Cold and wet and dreary, but an opportune time to do another Puscast. This one is covering the last 2 weeks of February 2014. References, as always, are available online, and I'm going to skip the usual blather and get straight to the literature. It looks like flu season is finally dribbling off the court. Thank goodness. It was a bad year. Second worst, I think, of my career in terms of hospitalization and complications. While I normally don't talk about diseases in children, this was an interesting study that looked at the complications and co-infections of children between the year 2003 and 2010 who were admitted with influenza. The only thing that I can't find in this study is how many of these kids had received the vaccine. It would be nice to know how many of these children actually got the influenza vaccine. But flu has a lot of complications. They are unusual, but they occur nonetheless. So they found 7,200 kids who were hospitalized with influenza. And it's not a huge number of people, but they had all sorts of bad issues. 14% had to go to the ICU, 1% died, and a hodgepodge of kids got pneumonia, asthma, dehydration, lung abscess, empyema, acute renal failure, myocarditis, etc., etc. They often got staphylococcal and pneumococcal infections as a complication of their influenza as well. So influenza is not bad just in and of itself as a bad viral pneumonia, but its downstream complications can cause significant morbidity, albeit in a relatively small segment of the population, which is fortunate. You can always tell, by the way, an anti-vaccine wackaloon, because they always would use the word only. 1% of kids died. Of course, I wished we lived in a perfect world, because in a perfect world, we'd have a good influenza vaccine. I often get asked how good the vaccine is, and I usually give a ballpark number, 50% chance of decreasing your chance of influenza. But that, of course, varies depending on the season and the strains circulating and the strains in the vaccine. There was a study out of Japan that looked at vaccine efficacy in the 2011-2012 season, and they found the flu vaccine efficacy was much less. However, they do note that they had very poor correlation between the circulating influenza and that in the vaccine. So it was a big mismatch that year in Japan, which brings the issues that when you get a flu vaccine, it can react to areas that are conserved between influenza strains and areas that are variable. And you still get some efficacy even if there is mismatch. Not a lot, but in a bad mismatch year, the vaccine efficacy was around 18% for unadjusted and only 6% for adjusted. But of course, that was then, this is now. How about the current flu season? Well, a report from the CDC and the MMWR suggests that getting vaccinated decreases your risk of seeing a physician for influenza by about 61%, which is 10% better than last year. But then the H1N1 is accounting for about 90% of the circulating strains this year. And the vaccine's pretty good if what we have circulating is H1N1. Really good match with that vaccine and that strain. I just wish we had a better vaccine. For those of you who are dying to know what the cause of the polio-like syndrome is in California right now, I went searching on the web and can't find much. The etiology is as of yet unknown, although 2 kids were found to have an enterovirus that can cause a polio-like syndrome. There appears currently to be no commonality, and it will probably be a couple more weeks before we get an etiology of this syndrome out of Northern California. There was a nice review in Medscape called An Epidemic of Epidemics, which goes over all the different diseases that have been sweeping across this country in the last several years, Lyme, West Nile, etc. Now we have the polio in Northern California, and as I mentioned before, chikungunya is coming our way. Life is never simple, nor is HIV. HIV-1 has 3 groups. There's a major group, there's some outlier groups, there's some subtypes, and there's some sub-subtypes. and there are circulating recombinant forms to make up a large hodgepodge of HIV, and they are not all the same clinically. At least in this study, out of clinical infectious diseases, patients who had the HIV-1A3/CRFO2 subscript AG had faster progression of HIV than other subtype A3 HIVs. These are evidently a predominantly West African strain of HIV, but the key thing here is that all HIV are not the same clinically. I have a clinical observation, and that's that people appear to have sex frequently. This leads to acquisition of disease quickly. This study looked at teenagers, age 16 to 20, who were men who had sex with men, and found that by the time they had 4 sexual partners, their rates of HPV approached 50%. So once you start to be sexually active, you get HPV really quickly. It's quite remarkable how quickly these viruses spread, and it gets to the importance of giving vaccines, the HPV vaccine, not only to young girls, but to young boys as well. They may not grow up to be men who have sex with men, but they're probably going to grow up to be men who have sex with somebody, and they're going to get and pass on HPV as a result. So why not break that cycle of infection and vaccinate your boys? Mine are. There's this goofy book called Grounding, the Greatest Medical Discovery Ever? ? I would say probably vaccines or fresh water. Wouldn't put grounding/earthing on the list. There are at least 3 causes of Lyme disease in Europe, but in the United States it's usually felt to be due to Borrelia burgdorferi sinculato. This study in Journal of Medical Microbiology looked at people in the South with ECM and symptoms consistent with Lyme disease at various stages. And they used DNA sequence analysis to look for Borrelia in these patients. And they found other species clustering in the southern United States that were causing symptoms similar to Lyme disease. They found not only B. burgdorferi, but B. americana and B. andersonii that were associated with Lyme-like signs and symptoms. So, like Europe, there may be more than one Borrelia that causes the signs and symptoms of Lyme. In the chronic Lyme world, there's this literature on cysts and L forms that are purported to be the cause of chronic Lyme disease. This study in CID reviewed all the literature on those particular manifestations of Lyme and didn't come up with much. As to the L forms, they only found them in patients who were basically having active Lyme disease, but they were extraordinarily rare in patients with Lyme. As to the round morphologic variants, these were found in patients who were not having signs or symptoms active with Lyme disease, having had MS and Alzheimer's, and so it did not know whether or not these were actually due to Lyme or not. And although patients failed to demonstrate evidence of Lyme by either culture or microscopy, similar problems with the cyst-like structures that were seen in patients that were thought to be due to Lyme, they also did not have any data to support that these were due to Lyme disease. So, quote, there is little evidence that supports the role of B. burgdorferi morphogenic variants in the pathogenesis of Lyme disease, and no evidence that they influence treatment outcomes. Not that this literature will convince anyone who either thinks they have or treats for chronic Lyme disease. When you think of syphilis, you think of a rash that involves the palms and the soles. This study is a reminder that syphilis has many an interesting manifestation, and you should think about it. Remember I mentioned earlier that people like to have sex? Well, this was a presentation of a 62-year-old male who had a diffuse erythematous papular rash that spared the palms and the soles. And the biopsies showed granulomatous inflammation. They used to say that to know syphilis was to know medicine, and at some level that may still be true. I occasionally see patients in clinic with NGU, non-gonococcal urethritis, and I usually see those that have failed standard therapy. What, pray tell, may be going on? This study found that M. genitalium, i.e. Mycoplasma genitalium, was a common cause, and that the big problem was it was often resistant to macrolides and occasionally resistant to quinolones, and that perhaps doxycycline would be the better choice, especially if you've had treatment failure with the azithromycin course. The problem, of course, is if you can't use quinolones, macrolides, or tetracycline antibiotics, we don't have a lot else to treat these with. Combine it with rifampin, chloramphenicol? Got me. Scrub typhus is due to Orientia tsutsugumushi. Used to cause Tsutsugamushi fever. I love saying Tsutsugamushi. And it's not found in the United States. It's predominantly found in Japan, Far Eastern Russia, parts of Australia, Pakistan, and Afghanistan, and the countries in between. And you'll be happy to know in this trial that doxycycline and azithromycin were equal in efficacy in treating patients with scrub typhus. A study out of Amsterdam looked at the incidence in microbiology of pneumonia in patients who were admitted with drowning, and that 37% of patients who almost died from drowning developed pneumonia. It was a not unsurprising hodgepodge of organisms, with Aeromonas leading the list, so they must have been drowning predominantly in fresh or brackish water. But they also had other waterborne organisms like Pseudomonas and Stenotrophomonas and Enterobacter and Acinetobacter, as well as a hodgepodge of staph and strep pneumoniae. So getting a near drowning episode does put you at risk for pneumonia, since the vast majority do aspirate at the time that they drowned. There is, however, no data to support the use of prophylactic antibiotics in these patients. So if you don't give prophylactic antibiotics, you should watch them very carefully. And if possible, know the microbiology as to what the patient drowned in. Was it fresh water, brackish water, salt water? They have different organisms. I would pity the man who fell into a septic tank and nearly drowned. I know you guys are sick of me harping on this, but infections are inflammatory. Inflammation leads to thrombosis, and thrombosis leads to cardiovascular events. And virtually every infection that's been looked at finds an increased risk of a cardiovascular event or a thrombotic event in the next several months. We also know that patients who are infected have higher mortality rates after discharge than patients with similar problems who were not infected. But what do they die of? Well, this study looked at the incidence of death after hospitalization for hospital-acquired pneumonia. And what did they die of? Well, infectious diseases and, wow, acute cardiovascular events. Who would have thunk it? I tell you, there's a career to be made for somebody with this whole issue of the prevention of post-infectious thrombotic events. I have been droning on about this for years. Somebody, please, get to work on that. And my other brilliant idea, urine transplants for recurrent UTIs. I tell you, there's genius in these podcasts if people would just pay attention. Me modest much? I am always entertained by the epidemiology of infectious diseases. Take, for example, Legionella, which you can get from shower heads, public fountains, nuclear cooling towers, peat moss, and now a case of Legionella in a gentleman who worked with a manually operated pressure test pump at a medical processing company. And this was the source of the Legionella. They found it in him and in large amounts in the pressure test pump. Where there is water, there is Legionella. Keep it in mind. There was a study a little while back that suggested that linezolid was better than daptomycin for the treatment of VRE bacteremias. This study looked at the results of daptomycin in the treatment of enterococcal endocarditis, and they compared patients who received dapto versus AMP ceftriaxone versus more standard therapies such as AMP, VANC, plus or minus gentamicin. And they found that patients on daptomycin did not do as well. They had more side effects and needed more changes due to a worse microbiologic and clinical response. Although there was no difference in mortality or hospital stay duration. But it would appear that daptomycin is not the go-to drug for enterococcus that perhaps other agents are. Not that we have a lot of choices in the treatment of enterococcus. Tea tree oil is a popular treatment for some infections. I've seen a couple patients come in with a bad allergic dermatitis to tea tree oil that was thought to be a chronic cellulitis. It can be quite the immunogen. It's often used to treat things like foot infections and toenail infections, and it smells really good. This was an in vitro study, but what they did was select for Staph aureus or Staph aureus that developed reduced susceptibility to tea tree oil. Say that 3 times really fast. As the Borg said, resistance is inevitable, and you need to bear in mind that patients can be using substances in the outpatient setting that can lead to bacterial resistance to the agents they are using. Whether there's any cross-reaction to other agents because of this mutation, it did not say, although it is interesting that these organisms that were resistant to tea tree oil did have altered cell walls. So I suppose there is the potential of cross-reaction at some point down the line. Now, I'll grant you, in this particular study, having a brain infection may not count, but patients with community-acquired bacterial meningitis have an increased risk for stroke. They have an increased risk for both ischemic and hemorrhagic strokes. And they found a vascular event in 22 of 152 patients with community-acquired bacterial meningitis. I don't know if I could call that another example of infection leading to thrombosis, since the infection is local to the brain. I'll give it half credit for this one. But stroke is common, and it is often a cause of death in these patients. Yet another study to show that cranberry extract does not prevent UTIs. This was a study that was done in 171 MS patients, and what was nice about this study is that they followed them for a year, where they either got placebo or cranberry extract, and there was, I'm shocked, no difference in urinary tract infections in the population. UTIs are not prevented by cranberries. And if anything, if used as part of a cosmopolitan, may increase your risk of developing a urinary tract infection. I have not been in the habit of recommending bleach baths. I have not been in the habit of recommending bleach baths for my patients with recurrent MRSA. I usually suggest Hibiclin showers. This was a randomized trial where they used bleach baths versus routine care for the prevention of MRSA in children. And they did find a 20% reduction in MRSA infections in kids using the beach baths, but it did not reach statistical significance, a p of 0.15. There's a pretty good study with about 490 kids in each wing. So while it did decrease the number of infections, the effect was minimal. I don't know one of the examples where the statistical significance may not be clinically relevant because there were fewer infections, and it doesn't look like they had the parents do the bleach baths as well, or pets. And so I don't know if this means that bleach baths should not be used. They shouldn't be used probably in just the kid, but perhaps like part of a nutritious diet, be used in the whole family to help eradicate staph from the environment. Because certainly when I have staph in a family, not only do the index case, I do everybody in the family, and I do all the animals, and I recommend a terminal cleaning and getting rid of ointments and new pillows and all sorts of things that may be excessive and are without good data to support it, but I try my best to get staph out of the entire environment. And I would predict that just doing the kid with MRSA would not be enough to eradicate staph in a family. But I think I will stick with Hibiclins because, as I've very clearly demonstrated, I cannot pronounce bleach baths. with any degree of confidence. It's especially complicated when the child plays with a toy boat in a beach bath. When he plays with a toy boat in a beach bath. No, he plays with a toy boat in a bleach bath. See? I did it. Oh, Jesus. Recently, a New England Journal article showed that most of the C. diff that manifested in the hospital was not acquired in the hospital. This study looks at a similar problem, Staph aureus, in an ICU, and they did whole genome sequencing to see how much of the staph was passed from person to person. And they found that about 18.9%, let's call it 20%, of transmissions, as judged from whole genome sequencing, were from patient to patient. So about 20% were nosocomially acquired, which of course is about 20% too many. In the United States, every year, 10,000 people are killed by drunk drivers. 92,000 are killed by hospital-acquired infections. So I think you could argue that hospital-acquired infections, i.e. ignoring infection control policies and procedures, is maybe 9 times worse than drunk driving. And they both have the similar feature that you know what you need to do to prevent it from happening. At least the drunk driver has the, quote, excuse, unquote, that the alcohol altered their judgment. I don't know how you could say that if you're a healthcare provider. And so while only 20% of MRSA were spread in this particular ICU, that is 20% too many. But as someone who's in charge of a hospital infection control program, I would hate to be blamed for spread of infection when, in fact, the other 80% were not our fault, though we'll still get dinged by it. So what is the oldest human infection? This article in PLOS God, I can't speak today. This article in PLOS Neglected Tropical Diseases suggested that it is leprosy, and that leprosy has been in the pre-humans millions of years ago. It's quite an interesting article to read, but they note that leprosy probably first started as an organism as we know it today 20 million years ago, when it lost a huge number of gene sets. And then about 10 million years ago, it probably jumped into our ancestors and has been with us since. Certainly it's been around for at least 100,000 years in human beings, but they think it goes back even further and probably infected pre-human hominids. Of course, these molecular techniques to me are like magic, so I have to take their word for it. I'll quote this one paragraph because I think it's particularly interesting. The evolution of leprosy bacilli occurred in 2 stages. The initial period up to 20 million years ago, during which the last common ancestor underwent, this is what's interesting, a massive reductive evolution to become a niche adapted parasite with the smallest and least functional mycobacterial genome. And a second period, approximately 10 million years to now, which began when the ancestor that followed 2 separate evolutionary paths. Thus, leprosy bacilli have maintained the leanest functional set of genes. During the past greater than 100,000 years in the second stage, it is almost certain that they have been in humans, in view of the sole reservoir status, strict parasitism, and clonal stability during global human dispersals. I think it's interesting that they had a, quote, massive reductive evolution as part of growing up leprosy. On a more common note of tuberculosis, the isoniazid rifapentine short course appears to be effective in solid organ transplant patients as well. It was not a huge number of patients, but it is probably the go-to treatment for latent tuberculosis. The quantiferon gold in this study is negative out of South Korea in a third of patients with miliary tuberculosis. It would appear that no test is helpful outside of a biopsy for the diagnosis of miliary tuberculosis. And finally, in the world of TB, inhaled corticosteroids do increase the risk of tuberculosis, but probably not influenza. Good news there, at least. What is the reverse halo sign? It is, on CT, a focal ground glass attenuation surrounded by a ring of consolidation. Boy, that doesn't help you much, does it? If you're interested, your best bet is probably to do Google images looking for reverse halo sign. But what's the importance of the reverse halo sign? If you take leukemic patients who are neutropenic and have invasive mucormycosis in their lung, 94% of them will have the reverse halo sign. So if you have that patient population and you find that on a CT, it's mucor. I guess histoplasmosis likes to live in bamboo. There was a report in Louisiana of histoplasmosis that was associated with cleaning out a bamboo field back in 1980. Now, evidently, they built a big bonfire out of bamboo and a bunch of people came down with histoplasmosis. Of the 19 people who were gathered around the bonfire, 17 got histo for sure, 11 were probable, and only 1 did not develop histoplasmosis. So next time you're near a bonfire from bamboo, don't inhale. People who practice supplements, complementary, and alternative medicine, the acronym is SCAM, are never content to do just one thing. They like to combine their pseudo medicines. This time what they do is they combined acupuncture with bee venom. It is evidently popular in Korea, but they have 3 cases of people who develop Mycobacterium chelonae infections doing bee venom acupuncture. And of course there's mesotherapy and all sorts of other ways that people contaminate the needles of acupuncture and stick it into the skin, and they usually get atypical mycobacterial infections. I always love these reports, which finishes with, quote, medical practitioners should be aware of the risk of NTM infections following invasive procedures and make efforts to prevent infections. Here's a challenge. Go on the internet, find any photographs or videos of people doing acupuncture with gloves on. If you watch videos of acupuncture and you're an infectious disease doc, you will get the heebie-jeebies. I'll give you a hint. There's exactly 1 photograph of acupuncture with gloves, and it's not being done by an acupuncturist but a physical therapist, i.e. at least somebody who has some knowledge of reality. And if you don't ask the patients, they may not volunteer the silliness that is, say, bee acupuncture or mesotherapy. And finally, one of the big risks of daptomycin is eosinophilic pneumonia. I've seen a pair of cases in my career. So to avoid it, maybe you'll give ceftaroline. No such luck. There's a case now of eosinophilic pneumonia that was induced by ceftaroline. Add it to your list of side effects. And that ends another Puscast, a review of the infectious disease literature for the last 2 weeks of February 2014. Refreshments? No. I'm having real problems today. There are no refreshments with this podcast. However, references are available at edgydoc.com, where you can find links to my growing multimedia empire. Some of them will also be on the podcast proper under lyrics, though not all of them. Otherwise, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation. Goodbye.